Hey, everybody, welcome to this month's LinkedIn Live event sponsored by, of course, Advise Health. I am Eric Rubenstein, Senior Director of Litigation, Fraud, Waste, Abuse, and I'm joined for this month's LinkedIn Live where we're going to be talking all things data analytics, policies, error rates, pitfalls, everything in the data space, and probably not everything because we'll be here forever. And I'm joined by one of our new directors here, Dan Olson. And for those of you that have probably seen on our webpage, an introduction to Dan. He started here a few months ago. And so, Dan, we're going to get going here. Give us a quick introduction. Tell us about Dan Olson.
Yeah, hey, thanks, Eric, and thanks everyone for joining. Really appreciate it. I have been a career person that has fought healthcare fraud, waste, and abuse. I've done it both on the government side and in the private sector. I was about 16 years with the state of Illinois, the Office of Inspector General, and then went into the private sector, finished up my career with Deloitte and was there for about 10 years and was VP over their product management and all of their data analytics. So looking forward to the conversation today.
Yeah, and Dan, we're as you know we're always excited to have people on our LinkedIn lives, and more importantly, we're always excited to have our subject matter experts that are advised people to talk about these kind of things. And the fact that you bring about 30 years of experience involving data and data analytics, I think we're gonna have a great conversation. And for those of you that are tuning in to this live broadcast, if you do have questions, we ask that you drop that question in the chat box, and depending upon who that question is directed to, either Dan or I will provide you with a response. As soon as we're done speaking, we'll be able to get you an answer. And if we don't get to your question during this time period in the chat, we will be sure to get an answer put out on LinkedIn. And again, this will be available as a recorded event after the fact, both on our YouTube channel and as a link through our email that comes every Friday as part of the newsletter that we get. So we got a lot to cover, Dan, and we're getting people during their lunch. So we want to be able to give people a little bit of time to finish choking down that delicious sandwich that they're sitting at their desk. So let's talk, there were some seminal things that occurred, and I know one thing that certainly started for you, kind of this trajectory of really getting even deeper into analytics was you went in front of Congress in 2012 and you spoke and you testified regarding data and things of that sort. So let's talk a little about that. Give a little bit of a background about kind of how you got there, what you talked about, and what the topics of conversation were.
Sure. No, happy to, Eric. So I was doing a lot of writing, a lot of white papers back in the day. Still continue to do that. And there was an outreach by congressional leaders to just offer a white paper or a point of view paper on just perspectives of how you would address examining the options to fight healthcare fraud, waste, and abuse. And so I had previously been working with several senior congressional folks, and had spoken with them, and they encouraged me to submit a response, which I did, and then that was vetted, and I was accepted as one of about 4 or 5 individuals to speak before the subcommittee of health on examining options to fight healthcare fraud, waste, and abuse. And so it was a great opportunity, and several things that I brought up at that point in time is the president had recently come out with a do not pay list, which was a great thing. And so definitely talked about that, what that was about. The Medicare Fraud Strike Force had been in existence since 2007. In 2012, there were about 9 major metropolitan areas that they had the strike forces in, and they were doing some really great groundbreaking work. There was also the integrated data repository that started back in '06, but it was still in a growth stage, and there was still a lot of formulative things that were going on. And really, I think as well is we were still trying to get out of the, as we all call it, the pay and chase mindset. We were trying to right the ship and not necessarily get rid of pay and chase. We would never do that, but start to incorporate a prepay or a prospective or a prevention first approach. We all know that, taking that approach is going to reduce a lot of the administrative overhead and the burden that goes with it. And quite honestly, the significant dollars that are lost as a result of that. And
Right.
so that was a big focus of the presentation, and just how we would start to use what was just becoming into vogue, predictive analytics. So a lot of great stuff there.
Yeah, and so you mentioned the integrated data repository, which for those that know the vernacular is known as the IDR, and the IDR took over from what was known as the Common Working File, right, or the CWF. The Common Working File was kind of this dumping ground where data was just thrown in, Medicare data, Medicaid data, just kind of all went into the Common Working File, and the IDR was a way to kind of create a transformative way of having that data in usable format. And then collaterally, there was always on the Medicaid side was the MSIS data, right? The Medicaid system data. And then a bunch of years ago, CMS undertook a project to create what they called TMSIS data, which was the T standing for transformative. The number one part of the TMSIS data updates was really to create a normalization of data so that when your former state, Illinois, submitted its data to the IDR or to the TMSIS system, it was in the same sort of format as New York's or New Jersey's or whatever else.
Right.
Because part of the issue, as you know, in the analytics space, is a data dictionary where the data fields are similar or the same so that you can look at data in the aggregate and make sure that it's kind of in there. The other pieces that you talk about is this whole premise of pay and chase, where now the catchphrase now is stop and verify, right? You want to make sure that we're in a stop and verify mode versus that prepay mode. And then the final piece is the strike forces, right? 2007, the first strike force in Miami starts. And then what happened was good, bad, or indifferent in percolating the model out. The problem that I think the strike force cities found, and I was working at the time in New Jersey with OIG, but we supported New York and worked a lot in New York. They started the strike force was in Brooklyn. And one of the big issues that we immediately identified was that the data model that they used in Miami did not really work the same as it did in Brooklyn, because in Miami, the fraud was so overt. Addresses that were dirt lots, DME providers. And again, the early point in Strikeforce was low-hanging fruit. The problem is that when you tried to export that model of data analytics to Brooklyn, it targeted areas where the criminals were a little bit smarter. They were actual buildings with actual clinics doing medically unnecessary or phantom services, and heavy kickbacks being paid culturally to similar groups of people. So the model, when it started in 2007, was a great model for that region, but as it grew, there had to be that adaptability that comes from it. Now, the last thing is 2012 is also when the Healthcare Fraud Prevention Partnership comes in. And obviously, there's a lot of data analytics that come in there. We have talked a lot about the HFPP in its as a premise and what value it could bring. Part of the challenges is that you have to be able to take this data, whether it be de-identified or not, but the aggregation of the data and some of the stumbles, for example, but prior to TMSIS was the sort of unusability of data. But where you're really touching upon is the importance of the integration of data for the purposes of being able to really identify real patterns and real fraud schemes, right? If Dr. Olson is billing Medicare for 8 hours a day for something, you're not going to come up as an outlier. But if you're also billing 20 other plans for 8 hours a day, that aggregation is what creates that buzz to make you an outlier.
Yeah, Eric, that's so true. And you hit on a few things that I'd like to just emphasize a little bit more. And the word I would start with is standardization. standardization of the data and making sure that you can congeal all of that data across plans, across Medicare, Medicaid, et cetera, and to be able to evaluate it is so critically important. And then to be able to determine, because a lot of times, we can talk about, the former data silos, and to say that they don't exist would still be a misnomer. And even, just looking cross state, border sharing of patients or providers is still an issue that where people, so to speak, hide. And you need to
Right.
be able to use the data analytics to be able to tease that out as well, to look across plans and to look at Dr. Dan and be able to see, am I looking at plan A and plan B and plan C, and I'm perhaps billing the same patients or different patients, the same codes, but at different dollar values. And to be able to bring all that together under one umbrella is really, really critical. The other thing that we talked about, or that I spoke about during the testimony, was just the network analysis. Again, back in 2012, in that era, that was something that was still a bit of a buzzword. And, we're still looking, even today, looking forward 13 years, how important that is, and to
Right.
understand and to tease out those relationships. And, because often, and I know you know this from your investigations, is it could be that we start off with Dr. Dan and we think he's the hot spot, but by looking the network analysis, we're able to expand beyond that, and we might find some other significant pockets that are really, really going to open up and reveal a lot more of our investigations.
And that's really a key point, Dan, because one of the things that we do when we do a lot of the training for our SIU clients, and we talk a lot about the investigative process, the investigative life cycle, and not to toot our horns, but when we do this training, it's people that have backgrounds like me who have come from that law enforcement organization where we deal with criminal, civil, administrative cases, and understanding that it's the best practice is that when you look at that data, looking at data will lead to other data needs. You can't
That's
just look
right.
at your data. You start at 30,000 feet and you start to drill down to really what is the important piece of it, which kind of segues into the discussion. When I was hired as an OIG agent in 1997, the data was obviously not what it is today, and I think we still have a long way to go in data. In 1997 at the OIG, we used a tool called Argus, which was really nothing more than an access overlay. You had the ability to get about 10 sort of standard reports. If you need a custom report, you had to make requests, and it was a whole thing. And then later on, towards the end of my career, we were on the ability to use platforms like 1PI and things of that sort, where you were able to get in and look at that. Today, the analytic tools that are out there, the analytic tools that we use, desktop functionality for
Mhm.
those. But the number one thing that we talk about a lot, and I say this, and for those of you that have seen some of the podcasts where Jason Eisengrind has been on, I say all the time, data will lie to you until you prove otherwise. And so that brings up kind of this whole premise of that data in itself can be a vacuum, and that there are some pitfalls out there. And pitfall may not be the right word, but if you are just going to fully rely upon that data, you are missing huge swaths of what your investigative life cycle could mean. And the example that I love to always give is 2021 CMS, the CPT codes changed, and the guidelines for evaluation and management or office visits changed, and they were no longer intrinsically based upon time. They became more intrinsically based upon the actual care and the coordination of care and what they call the MDM, or medical decision making, of the provider with the patient. And so if you're a specialist and you're doing a comprehensive exam, that might be a level 4 visit. And before you know it, you might ratchet up 24 hours pretty quickly. And it might create a situation where you're considered an outlier. But you really may be an outlier with an explanation or a reason or a rationale. So the biggest problem that I see in the world in data is that we tend to rely too heavily upon the data as the ultimate answer to what the issue is to be resolved. And data really should be your starting point to a large
That's right.
extent.
Yeah, yeah, Eric, so good. We could probably spend the rest of our time only on that part of the conversation, truly. Um, I like to say, well, let's go back. Let's step back a number of years when, going back to the old SURS system, surveillance utilization review systems, they were known as outlier detection or exceptions or anomalies. And typically, way back when is it was 1.5 standard deviations from the norm. I mean, that's just how you identified it. And the way I would approach this is it's just an indicator. Okay, we collectively as healthcare fraud examiners need to keep that in mind. Is this is an indicator? It's something different. It's something I like to use the word. It's interesting. Bring what I call a healthy curiosity after you've identified or run your data analytics. Just because I am billing a lot more than, say, Dr. Eric does not necessarily make Dr. Dan a bad individual or billing incorrectly. As you just aptly said, it is a starting point. And so then now we have our data results. It's good to compare against like providers. Peer analysis, I would say all day long, is a great approach, a great methodology. But you want to bring in your other specialists. We can't just be in a room. I love data scientists, but we can't be in a room just with data scientists. We need to be able to bring in our policy folks. We need to be able to bring in our clinicians. We need to be able to bring in any other individuals that are going to have an intimate knowledge of the data. We used to have a meeting that would involve all of those individuals plus our technology team, because they're going to be the ones that are running the front end edits or those preventive measures, and they're going to have insights as well into, is something turned off? Because we've all seen that, is that, there might be a policy or procedure that's in place, there might be an edit that's in place, but then it's turned off, and then, oh my goodness, the floodgates open up. And so we need to keep all of that into consideration as we are evaluating. And so, going back to the statement you made, it can't just be about the data. It needs to be about the data. The data needs to be there and needs to present that unbiased approach, because we cannot bring bias in. I would argue that we likely do inadvertently, but by generating the data results and then bringing in all these other sources, bringing in third-party data sources, whether it's vital records or professional regulations or anything like that, to be able to triage all of your data or triangulate rather all of your data, is going to tell a better story and is going to help you move away from those false positives.
Right. Well, and you bring up a great point, which is that you have to look at data in kind of a 360-degree view, and that's where you can't just silo yourself. We talk a lot about, and particularly we talk about it on our OIG Roundtable podcast, about the importance of integrating payment integrity in a wholesome group. One of the examples, and you kind of touched upon it, a provider can be an outlier, but it can be a legitimate outlier. And the example I always love to give is, I'm an ophthalmologist and I do general ophthalmology, and I hire Dr. Dan to come in, and you are a retinal specialist. Well, for the past year or 2 years prior to you coming, I didn't bill for certain codes that were particular to macular degeneration diagnoses or retinal detachments or things along those lines. Now, all of a sudden, my practice's billings are showing a hockey stick change in the integration of some of these other items, services, and procedures. They make me an outlier. And so while from a peer study perspective, I absolutely agree that you start with peer studies, because at the end of the day, you want to have apples to apples. You want to be able to articulate properly where those apples to apples are. But, ophthalmologists are not ophthalmologists until we've been able to identify that they are, right? Because we all know that specialty codes are just for that specialty. They are not for that subspecialty. And so it's important to be part of that integration of your investigations to say, okay, why is Dr. Eric's practice on all of a sudden people are showing up now with a diagnosis of macular degeneration, retinal detachment, whatever it may be. And all of a sudden, there are all these items, services, and procedures that he never did before. Well, that's where you bring in your enrollment team. Hey, has there been a change in Dr. Eric's practice? Oh, yes, Dr. Dan is now part of that practice. Oh, Dr. Dan is an ophthalmologist, but he is a retinal specialist. Aha. Again, it doesn't mean that there's fraud, waste, or abuse. The data has lied to you because we have been able to show that Dr. Eric's practice is an outlier, but it's not inherently an FWA issue, and that integration of policy and all of that kind of comes into play, which kind of then leads to the other half of the discussion that I want to have before we run out of time, which is this whole premise of error rates and the integration of policy and the integration of data models and how that all works, right? I mean, we see in the analytics space, we have seen instances where analytic vendors claim to have inordinately low error rates, and sometimes it's founded on some empirical analysis, sometimes it's anecdotal, but these are all pieces of the puzzle that are going to be integral to whether or not your SIU's ROI is going to be tangible or intangible, right? Your tangible are going to be recoveries, offsets, your stop and verify, and your intangible are going to be those opportunity costs. You know, when Eric, as an investigator, is spending a day vetting out a data response that turns out to be a false positive, my opportunity cost was I could have been working on something else, right? So talk a little bit about like all of these kind of pieces of the puzzle, because they all kind of ultimately result in one thing, which is output.
Right. Yeah, so true. I would sit here all day long and say doing measurement is a great thing. Okay. I would say that measurement does not occur enough. And to do measurement and to do measurement properly is you need to be doing it month over month, quarter over quarter, year over year, and you must be doing it consistently. So those are some key ingredients, some lessons learned, if you will, that I would bring into measurement. Now, if you start to read reports, if someone is purporting that they have, a 85% ROI or a 98% accuracy or whatever, then I think I would suggest that you need to pause. And I think you need to ask a series of healthy questions to help wrap your arms around that. And, some of those questions can be, what is the time period you looked at? What is the membership that you looked at? What is, the dollar volume that is driving that? Are you looking across all plans, or was this one client and one specific niche taxonomy that you looked at that really drove that up, and that's what you're reporting? So I would not sit here and say that, the report was inaccurate. I would say that there's a lot of underlying information that I would encourage all of us to be able to ask that series of questions, to be able to get comfort in that 85% number or that 98% number is an actual true and applicable. And the other thing you need to, caution you on is, how does that apply to me? Because maybe, again, you're a very, very large plan, and the fact and figure was on a very, very small plan. So does that equate? Going back to your apples, oranges, that would be an apple and an orange, because there's just several variables. Okay, we talk about data, we need to talk about variables that come into play to drive that.
And the one thing, Dan, that always stands out to me is when we're talking about a data analytic tool, it also becomes, while the tool is going to have applicability across whoever they have as a client, right? The entire spectrum of payers potentially, there are some kind of niche things. Number one is that the developers, the sales team, whoever it may be that's your point of contact, has to understand what your payer specific data is like. For example, one thing that we know happens in Excel is Excel likes to drop sometimes leading or trailing zeros.
Yep.
And does the data that you're ingesting have that happen? And for example, when we look at claims, we know that payers all create either a document control number or
Yep.
an incident control number or an identifying, whatever it's, sometimes they call it an ICN, a DCN, whatever it is. And that creates that uniqueness for that claim when it's kind of, time and date stamped. We know in the CMS space, the document control number is a combination of the Julian date with
Yep.
actual receipt times and all that. And you have to understand that, particularly when you're looking from an FWA perspective, it's understanding, is the provider resubmitting the same claim? Is there an adjudication? Is there a change? Whatever it may be. And sometimes if the vendor of the analytic tool doesn't understand the numerical naming convention, every single spot on a claim number has a reason, right? And
Absolutely.
there's a data dictionary that explains it, whether it be Julian date, calendar date. Your vendor has to understand that, particularly when you're talking about claims that may have a trailing number of a 1 or a 2 or 3. Is that a resubmission? Is it an adjudication? From an investigative perspective, if I have a claim that's been submitted and rejected and it's resubmitted, and my control number stays the same with the exception of putting a 1 at the end, and I know it's a resubmission, I need to also know what is the thing that made it differently, right? So your vendors have to understand when they do their modeling, they need to understand very deeply every piece of that data, and more importantly, what the meaning behind all of that data is, because models can be wrong if they don't understand the data correctly.
Oh, it's so true, so true. An example I would think of here, Eric, is clearly, you need to understand the data without question. Let's say that 3 or 4 times. But there was a situation in my career where we were looking at a data set, and again, it was just the initial blush, and it looked like, oh my goodness, we have substantial duplicates here. Oh my goodness, I mean, like a ton. What it ended up, before we presented it to the client, thankfully, was they were dual eligibles. And so you saw there was a Medicare and a Medicaid indicator on that. It looked like 2 different claim lines, both being paid on the same day, same procro, blah, 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 looked like a duplicate. Once we said, oh, no, this is a dual eligible. So therefore, we addressed that and moved on. So it's things like that that you need to consider. I'd like to take a moment and talk a little bit about model development life cycle.
Please.
I think that is really, really critical.
And just to interrupt you real quick, Dan, if you could just explain to everybody who may not be like as deep into the weeds of data, what is modeling and why is it used?
Right. So that goes back to, thank you, Eric. When we think about predictive modeling, there are, from my perspective, there are many different types of analytics. Okay, there are what I would call kind of your foundational, whether we call them policy based, so more binary yes no. You shouldn't go beyond X number of DME catheters or whatever that is, and if you do, then it's wrong and it's a collectible. Then you move into more of those behavioralistic type of analytics where you are comparing Dr. Dan to Dr. Eric and seeing, are there distinctions there that raise areas of interest? Again, let's go back to that healthy curiosity. And then there are true where we get to, heavy into the data science where we are using true predictive modeling and generating those. And all 3 of those are important, and collectively together, I would argue that is a healthy and a good tool set, if you will, to bring into your analytics, along with a series of clinical analytics. Let's not forget that, there are these standards of care that drive the major disease categories, and to be able to look at that quality of care perspective. And so you bring all of that together, and that provides you and the client a good overview of your data set.
Right. And I'm glad you brought that up, because a couple of weeks ago, Matt Kachansky, Wade McFall, and I were talking about some of the things involving data. And one of the things that we actually started to talk about was diagnoses codes are really, they're like the redheaded stepchild in the data analytics space, because oftentimes we tend to forget about the fact that diagnosis codes become intrinsically part of that methodology. When we're talking about NCC, National Correct Coding Initiatives, and we're talking about the more importantly, the MUEs, the medically unlikely
Yep.
edits
Yep.
about these diagnoses. In the example, to kind of bring it back to you with your binary yes, no, the one thing that always boggles my mind is the instance in which the DME supplier is submitting a claim to a payer for a right knee brace, and the patient has a prior diagnosis of an above the right knee amputation. And
Yep.
that should be a very simple, that's a binary,
That's a
payable
do
yes,
not
no.
pay.
And we miss it all the time. We miss it all the time. And I think that, my other favorite one is there's a procedure out there called enhanced counterpulsation, or external enhanced counterpulsation, ECP or EECP, and the HCPCS code is G0166. And it's a procedure where the patient gets 35 treatments, either once, 1 hour, one a day, or 2 treatments, but it's a total of 35. And it's for people who have a non-surgical ability to have their unstable class 2 or class 3 angina treated. I worked a whole bunch of these cases. And the thing that I always found amazing to me was that the patient did not have the diagnosis of unstable class 3 angina until the first day of treatment.
Mm.
And one of the requirements in the policy is that the patient gets a referral from a cardiologist that attests to the fact that they're not a surgical candidate. So one would suspect in the billing history that you would see at some point a visit from a cardiologist in which the diagnosis of unstable class 3 angina non-surgical is there. And it's, to me, a similar yes, no. That how is it that on the day you get the treatment, you have that diagnosis, but you didn't have it previously? And that's where I think that there's this integration where people that tend to work in the SIU space tend to sometimes focus so heavily on CPT and HCPCS codes and forget about that clinical piece, which
Right.
is which oftentimes is your medical necessity and policy based
Yep.
portion of the data. So
Yeah.
um,
Agreed.
yeah, and then it becomes a piece of the puzzle that I think we tend to focus so much on the thing that drives the money, which is the
Right.
HCPCS and the CPT code, right? And in
Yeah.
some instances, there's such a range of diagnoses, right? For example, E&Ms, almost every diagnosis is going to fall under an E&M, but uh, EECP is going to have one diagnosis, and so we need to be able to focus, to that point. So, as we start to wrap up, and we're kind of running out of time, but we're gonna have to do another session of this, because honestly, Dan,
I
there's
look
just too
forward to
much.
it.
There's too much inside of the Dan Olson and Eric Rubenstein's questioning brains to get to this. But kind of as we wrap up, what are your, on this portion of this conversation, what are kind of your final thoughts on this? And a couple of things to think about is, first of all, we've clearly gone from where we were to where we are in leaps and bounds. I think we still have a long way to go. I think, unfortunately, there's a lot of discussion about the 4 letters of the alphabet that everybody loves to use, AI and ML. And I know just enough to know that when I put into something in ChatGPT, it tells me something, and I know that that's AI. But, as all of this kind of grows, our ability to understand things has to grow with it. And as investigators, we have to continually have that thirst for knowledge and that
Yes.
hunger to learn.
Yes. Yeah. Yeah, Eric, I'll just take right off on that. So I would, what you just said is I would put into 2 words, and I would say healthy curiosity. I think we as investigators need to continue to foster a healthy curiosity, not just with ourselves, but with our teams, and mentoring our teams and growing them in this whole process. There are new technologies without questions, AI, ML, all the alphabet, right? That are coming in because, it's like two steps back, one forward. And what we are starting to see is the realness or the appearance of real in claims that truly are not. So let's set that aside. Let's make that another conversation. But I would say collectively, healthy curiosity is good. I would also say, when you talked about earlier on, you talked about Miami and you talked about Newark or Jersey. We as data analysts, data scientists, investigators, we can't do a wholesale lift and shift of our analytics. We will fail every single time. We have to, it's great to have a foundation, absolutely, 100%. But then we need to be able to bring that in, and on our next talk, we can talk more about or talk about model development life cycle. And part of that is the whole tuning and training, or aligning the analytics with the client, with the plan, making sure that they follow the policy, the contract, the fee schedules. If we go blindly and just start presenting leads and findings without taking those foundational steps, we're missing it. And so, again, let's talk more about that. The other thing that I would say, and that I think is really, really important, again, you touched on a little bit, is we need to be vigilant in everything that we do. We need to be very purposeful and intentional in how we approach things. But as I say that, and this is how I'll close, is we also need to be unpredictable. Because if we are in our analytics and we think back to just setting a floor for a threshold or setting a percentage or a count or something like that, the fraudsters are going to come in. They're going to figure it out very quickly. They're going to subvert it. They're going to find that dam and they're going to open it up and blow right through it. So let's talk more about these things as we go into our next session.
Yeah, you're 100% right, Dan. And, I say one of my favorite catchphrases that I've been using over the past few years is the circus never changes. It's just the clowns under the tent that do, right? The fraud schemes that we see tend to be versions of fraud schemes that were there in some other way, shape, or form, right? For example, when we see what's going on with all of the telefraud that results in the DME, the genetic testing, and the sort. Years ago, we were working on cases that involved boiler room operations that were reminiscent of the Wolf of Wall Street days, involving movement of patients for diabetic testing supplies. It's a similar scheme. The DME schemes of people getting the RoboCop suits, right? Neck brace, back brace, elbow brace. It's the same thing. There's just been an integration of technology and an integration of people being able to take those old schemes and move them to today's payment models and things of that sort. So we're going to have lots to talk about in the next one. We're going to find a date. We're probably going to do this. We'll give people a little bit of a break. I think we have a couple of others scheduled. We'll get to a part 2 of this. As always, Dan, I learn a lot when I sit and talk to you, and I could sit and talk this stuff, and we can get our geek on fraud, waste, and abuse for hours, because it really is. It's really great to hear. You've been in this space for such a long time, and you were in this space kind of when it was still growing and becoming something. And so there is a lot to be learned from just sitting and listening to people tell their war stories, because they really do recycle themselves. So Dan, as always, great chatting with you. For everybody that tuned into this month's LinkedIn Live, we appreciate you taking the time to listen. For those of you that are choosing to listen to this as an offline event, we appreciate you taking the time to integrate it into your day. And again, if we didn't get to your questions, and you have, we will get responses and we will get those over to you, I promise. And as always, again, you can get your newsletter sent to you directly to your inbox. Just go to our website, advizehealth.com. You can sign up to get that newsletter sent to you every week. It includes links to our LinkedIn Live broadcasts. It'll let you sign up for them, our OIG roundtables and the like. And as always, we appreciate everybody tuning in and taking the time. And until the next LinkedIn Live, and until I see you all in the next OIG roundtable, take care.
Thank you.